Well, welcome everybody to the Healthy Lives, Healthy Communities first breakout session. This session is Opportunities and Challenges in Addressing Mental Health Disparities. So thank you for coming to this. My name is Nick Butler. I'm a project director at the Center for Health Policy. I've had the privilege to be working there for the last 6 years on a variety of issues, including the Health Equity Project. We'll have 3 panelists today, and what we're going to do is hear them present for about 20 minutes each on their topic, and then afterwards we'll have a question and answer period. So without further ado, I'd like to introduce the panelists all at once here before we get going. We have Dr. Daryl Hudson. Dr. Hudson is an assistant professor with the Brown School of Social Work and a faculty scholar with the Institute of Public Health at Washington University in St. Louis. His research agenda is the role of social determinants of health, and his current work is largely concerned with how socioeconomic position and social context affects health across different racial and ethnic groups in the United States. He completed his doctoral studies at the University of Michigan School of Public Health, where he also received his MPH. Welcome, Dr. Hudson. We also have Rita Adkins. Ms. Adkins has over 18 years of experience in mental health services research and project management. She is currently the PI for the evaluation of the ER Enhancement Project in Missouri, and that's at the Missouri Institute of Mental Health. She was the evaluation coordinator for the Screening, Brief Intervention, and Referral to Treatment Program, or SBIRT, and was the project manager for the Consumer Operated Services Program Coordinating Center, evaluating existing consumer-run peer support programs for adults with severe mental illness when offered as an adjunct to traditional mental health services. So welcome. And we have Luann Tanner-Jones. For much of her early career, she provided direct services to students with a vast array of disabling conditions and worked with the families as well. In later years, she held many administrative positions working in both private and public schools and agencies, culminating in her present position as Director of Special Services and Section 504 Coordinator for Columbia, Missouri Public Schools. Welcome, panelists. All right, Dr. Hudson.
All right, thank you for that introduction, and good morning to you all. So today I'm going to talk to you about understanding racial differences in mental health, and try to spend a little time talking about St. Louis, where I'm located now. The first thing that I'll ask people, so my background is social epidemiology. Who in the room has heard of social epidemiology before? A few people. So social epidemiology is concerned with patterning of disease, particularly around issues of social determinants of health. So looking at race, ethnicity, socioeconomic position or social class, looking at social context or where people live in neighborhoods. It's also very concerned with the blurring of the lines between physical and mental health. So oftentimes we have this very bifurcated, dichotomous system in which we think about mental health and we think about physical health. So that'll come up a little bit later, and why I think that removing that barrier between physical and mental health is very important. So if I ask people in the room what health is, knowing the people in here are probably concerned about health equity, you probably give me answers that I would expect from this type of audience. But if you've been a clinician before, a lot of times people come into your examination room and you ask them about what's on their mind, and the last thing they're thinking about is their actual health. They're thinking about their employment situation or their children or education and things like that. So I think it's important for us to think about what do patients or the communities that we're trying to serve think about on a daily basis. Oftentimes we think about health as an individual decision-making thing, or maybe not people in this room, but in general, folks think about the individual decision-making around making healthy choices. So maybe it's eating fresh fruits and vegetables. Maybe it's if we had a line outside the room this morning and you had to line up between say, a bowl of oatmeal, the vat of oatmeal versus the stacks of pancakes, who would go for the pancake line? A few people, a few brave souls this morning admitting that they would go for the pancake line. We do have candy on the tables, though, this morning. So oftentimes we think about these individual decision-making, health behaviors when we think about health. But what about things that we can't control, like where we live? So this is a real picture from Flint, Michigan when I was a graduate student. I took this photo. Or you think about a place where I'm from, Detroit, Michigan, which is always in the news. I could talk offline to you about Detroit and what Detroit is really like. It's not always what it seems to be in Time Magazine or in New York Times. So what are those resources in those neighborhoods like compared to, say, a place like this, like Pacific Heights in San Francisco? And obviously you can think about the food resources that go along with such neighborhoods. So whether it's a preponderance of fast food restaurants, liquor stores and things like that, or whether you have access to fresh fruits and vegetables that are easily accessible and affordable to you. So just to cap all that, thinking about the World Health Organization's definition of health. So health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So probably everyone in this room has heard or read that definition before. And we see it all the time, but do we really think about it in the way that it presents itself? So oftentimes we think about health in relation to disease status. And it's really even more challenging when we think about mental health, because we're processing our world around us through our eyes, and our emotions and our relationships with other people are telling us where we stand in that social hierarchy, right? And so it's something that we have to pay a little bit more attention to in terms of mental health. You can't just see it like it's a broken arm or a complication of diabetes or something like that. So I'll talk a little bit more about why mental health is such a challenging thing to talk about and to address. So the panel is focused around disparities. People know what disparities are, I'm assuming. What's the definition of disparity? Anyone? We only have a few people in here today, so any brave souls want to take a stab at defining a disparity?
It's when you see something that's different between two groups.
Okay. The key element is different. Anyone else want to elaborate? So my working definition of disparities is around differences in health that are usually plausibly avoidable, that are often caused by some policy or practice that can be removed. So they're unjust differences in health, often around racial ethnic lines or socioeconomic lines. So we think about disparities in terms of these disease outcomes. So one is infant mortality. So if you look at black-white differences in infant mortality, over a long period of time, you always find this twofold difference in infant mortality in which blacks have twice the rate of infant mortality than whites. Same thing with life expectancy at birth. You see that blacks on average have about 6 or 7 years less life expectancy compared to whites. And we've probably seen this quote before by Martin Luther King: of all forms of inequality, injustice in healthcare is the most shocking and inhumane. I like this definition, and it kind of informs my working definition of disparities by one of my mentors, Paula Braverman, who defines health disparities as potentially avoidable differences in health between groups of people who are more or less socially advantaged, or advantaged socially. And then we have the NIH's National Institutes of Health definition of disparities, which says differences in incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the United States. So to summarize, these are differences in health that are systematic and plausibly avoidable, oftentimes influenced by policies or practices, and put socially disadvantaged groups at further disadvantage with respect to their health. So one of the outcomes that I'm interested in is depression, which I don't have to tell people in the mental health panel how debilitating and widespread and costly depression is. Obviously, not just in itself, but also, again, blurring the line between mental and physical health, thinking about how depression is associated with self-care among patients with chronic diseases, associated with poor immune system functioning. But what's interesting about depression is that when we look at large-scale national psychiatric epidemiologic studies, we find something curious, which is that every study that's ever been conducted, any national study, finds that African Americans have lower rates of depression compared to whites, which may not be news to some of you in the room, but oftentimes it's something that people say, whoa, that can't be. And it doesn't make perfect sense when you think about physical disparities in health. So obviously if you talk about heart disease, hypertension, diabetes, you name it, you find that blacks have greater rates of all those morbidities and overall mortality than whites. So it's interesting thinking about from a disparities perspective in mental health that one of the most common forms of mental disorder, you find that in national psychiatric epidemiologic studies that the difference favors blacks as opposed to blacks having greater amounts of depression. So if I said, do you believe those numbers? Do people believe those numbers? It's a real question. Do you believe those numbers? So a lot of people say, well, it's got to be the measurement of these disorders, particularly depression. And mind you, these are major psych epi studies. So this is the epidemiologic catchment area study, national comorbidity study, replicated, the National Survey of American Life. All of these samples have nationally representative samples. All of them have done very elaborate sampling framing, race match interviewing, all the state-of-the-art methodology to arrive at these numbers, which are pretty consistent across all those different states. So if there was a difference, you would think there would be something very, very systematic going on there to explain something like that. So I think that's the first major point that I want to make is that when we look at depression, for instance, we find that blacks have lower rates of depression than whites. So part of my research agenda is to set about why do we see these differences in depression. So obviously people in this room probably think about access-related barriers, so people don't have access to mental health care, and so that's why we don't see those rates. But that doesn't explain those psychiatric epidemiologic study findings, because these are studies where people knock on the door randomly and interview people and put them through one of those structured clinical interviews to arrive at those diagnoses. Sometimes people say, well, it's biased measures of providers. Again, not looking at the provider side, but the measurements are used consistently throughout those different studies. And if there was going to be something systematic, you would think that it just doesn't seem to sit well, saying you would see those same rates if the measures were that biased, especially when you look at all the different methodological things that people have done in those studies to arrive at the best estimates. Sometimes people look at patient-provider characteristics, again, which wouldn't inform those large data at the national level, but we do find that there are differences in diagnosis of depression and other mental disorders by race. However, we also find that just in general, oftentimes providers are not great at diagnosing depression and other mental disorders in general for everyone. And so if I get time, I'll show you some data from when I was in the Bay Area from the Kaiser Division of Research that indicate diagnosis of depression in general is poor, not just across race. And so, actually, I just prompted myself for that study. So a study that I did with the Kaiser Division of Research, we wanted to evaluate whether there were racial ethnic differences in depression recognition among patients who had significant self-reports of depression, depressive symptoms. And what's unique about this study is that all these patients had diabetes, which diabetes is closely related to or associated with depression. So providers should be on the lookout for issues around depression. And we know that depression is underdiagnosed in general, may be worse in racial ethnic minority groups. We know that diabetes is a major issue for racial ethnic minority groups. So we looked at this study, a diabetes study of Northern California, to test whether there was a systematic difference in racial ethnic diagnosis of depression among patients with diabetes. I'll flip through to get to the main findings. Overall, we found that only 15% of Kaiser patients. So what's unique about Kaiser is that this is a closed healthcare system. So thinking about the VA system, it's a provider and an insurance company all in one. And so patients aren't going in and out of different organizations and different types of care organizations. They're all within the same network. And they try to get people at once. So if someone comes in for one condition, they try to catch them and see them for other issues that they might be dealing with at the time. So a very unique and innovative healthcare system. But overall, among patients with diabetes in that particular sample, only 15% overall of patients with significant self-reported depressive symptoms were recognized with depression. And then African Americans were only 12%, Asians 8%, Filipinos 8%, Latinos 14%. So overall, pretty poor. African Americans and Filipinos were significantly poorer than whites, but overall pretty poor rates of depression diagnosis, even within a vulnerable population like that. So thinking about St. Louis, I was working with a transdisciplinary group between St. Louis University and Washington University recently, and we published a set of policy briefs around different areas of health in the St. Louis metro area. One of the things that I worked on was mental health. And overall, we found that prevalence of mental disorders in African Americans and whites in St. Louis City, so we can really only find data on depressive disorder. And we found that the same thing that we found in those national studies was going on in St. Louis City, where African Americans had lower rates of depression than whites in St. Louis City. In St. Louis County, it was the same story. However, when we looked at ER, so my colleague will tell you shortly that emergency room visits for mental health are problematic for a variety of different reasons. But we found that African Americans had a 121% higher use of emergency room for mental health conditions. So that does indicate that even though the rates might be lower, when people are dealing with depression, it could be more debilitating. It could be episodes that are more severe or longer lasting. And certainly data from national studies indicate that as well. As well as the hospital stay, so African Americans are staying in the hospital longer for mental health conditions compared to whites. Obviously, when you think about the cost of it, the costs are staggering, so I'm sure you'll talk about that a little bit later. And proportionately, it's a lot greater for African Americans compared to whites. The reason why I think all this information is important is thinking about, which goes back to those pictures I showed you at the very beginning, thinking about social context. So if you think about St. Louis is this very segregated city. Resources are certainly patterned by race, ethnicity, and social class in St. Louis. And so we can see that the conditions in which individuals live and the risk factors associated with those risk factors are related to not just disease, but also health behavior. As I mentioned, segregation is a major problem throughout the United States. Certainly within St. Louis, so looking at where African Americans live, mostly in the north area of the city and the county. But when you look at things like diabetes, so one of my other studies looks at diabetes, we can see by zip code where the highest rates of, say, diabetes are in the city. We can also see where there's the most cases of hospitalization. And they're all located in areas where there's a predominantly African American census tract. This is important because if we think about how stress gets into the body, we process, like I said before, where we're at in society. And there's this cascade of physiological function that sets off within ourselves that can lead to depression, can also lead to chronic disease. But one of the things that is an interesting hypothesis that a number of my colleagues and I have been working on is how poor health behaviors could potentially buffer the negative effects of stress. So if you think about where you live and what you have access to cope with, if you have a bad day, it's Friday, it's the end of the week, you drove through a driving rainstorm to get here, you feel bad, stressful, what do you want to do at the end of that week? You don't have to answer me, people will probably be too honest. But you think about it, the things that you might crave don't always go hand in hand with the public health message, right? Some of you might say, well, I want to go out and exercise, or I want to go hang out with friends or something like that. Some people will say, I want to go to the bar, I want to go to happy hour. Some people will say, I want some good comfort food to comfort me. So one of the things that could be going on in St. Louis is that people are coping with stress and the socioeconomic and financial strain that they're dealing with, potentially with the resources that are proximally located in their neighborhoods. So there's a preponderance of fast food restaurants, there's a preponderance of liquor stores and things like that. So perhaps one of the reasons why we see in the national studies and within St. Louis lower rates of depression and other mental disorders is because people are finding things that work for them that could potentially buffer the mental health problems that they might have, but at the cost of their physical health. So just to wrap things up, that's one of the things that I would like for people to think about is kind of breaking down this barrier between physical and mental health and thinking about how the two can inform each other and how all that ties back into disparities or perhaps the lack of disparities that you see between blacks and whites in regard to depression or other mental disorders nationally and in St. Louis. Thanks.
So I'm Rita Adkins, and I'm going to talk a little bit about improving access to community mental health through the Emergency Room Enhancement Initiative. The goals for today, I'd like to give you a little overview of the Emergency Room Enhancement, talk a little bit about how the need came about for it, how it's been implemented across Missouri, and I work for the Missouri Institute of Mental Health, talk a little bit about our role in the project. So why do we need the emergency room enhancement? The SAMHSA, the Substance Abuse and Mental Health Services Administration, released a report in January about 2012 results. 43.7 million adults age 18 or older have a mental health diagnosis currently. That is 20% of the population. And the National Emergency Department survey reports that 12.6 million visits to ER involved participants with a mental health or substance abuse disorder. Many times these people go to the emergency room, they get stabilized and released and end up right back in the emergency room. Actually, one of the study sites that we have an individual between I think it's May and November of 2013 had 43 ER visits, and 8 inpatient stays in that 6-month period. And 1% of Americans account for 20% of health care. And a lot of times these visits that are covered for mental health and substance abuse, about 60% of that is covered by state budget. So it's very impactful across the state. So why do these people go to the emergency room for help? The top 3 reasons they reported, number 1 is cost. A lot of them are underinsured or uninsured. Second, they think they can handle the problems themselves. Stigma is still really strong out there against mental health disorders. And third, they just really don't know where to go to get help. They're not really told that at the emergency room. They're just released and sent home. So how did this need come about? A little history of the need. It began with deinstitutionalization, and hopefully I don't have to say that word again because I stumble over it every time. So I might just say the D word. After that, that began in 1956, actually, and at that time there were over 500,000 people in back wards of state hospitals who were just receiving custodial care. There was no hope for recovery, so there was no treatment involved. And then, like in the early 60s, there was a task force that looked at this, and they introduced the Community Mental Health Centers Act. They thought it would be better for people. They'd get better care through the community services. This shifted the cost from state to federal budgets because the money went directly to the communities and not the state, which caused a lot of the state hospitals to close. And also the introduction of psychotropic drugs because it was cheaper to treat people with the drugs and release them from hospital care. There were reactions to the D word, and that is for every action, there is always opposed and equal reaction. Even though it was well-intended, there were unintended consequences for the D word. Looking at a definition, the law of unintended consequences hold that almost all human actions have at least one unintended consequence. And that they are a common phenomenon due to the complexity of the world and human overconfidence. So as well-intentioned as it was, there were some unintended consequences, including lack of coordination between the community services. It wasn't really thought out how to coordinate the services that the people needed who were being released. And there was lack of adequate community resources, so it resulted in increased homelessness. A lot of people were released to families that didn't know how to cope with it, that were ill-prepared to. Some people ended up in nursing homes, but a lot of people ended up on the streets. And there were real challenges. They had been under custodial care for years. They're released into the real world, so there were they didn't know how to handle things, lots of drug use, which resulted in criminalization of mental illness. A lot of people were thrown in jail for transgressions, and there were lots of challenges to the existing systems. So, a lot of recent events have brought to mind, Sandy Hook, some school shootings, that there's a real need for mental health services right now. So Governor Jay Nixon set some funding aside the initiative to increase access to mental health services. And part of that is the Emergency Room Enhancement Program. So how does it address some of the unintended consequences? The biggest one, the lack of coordination between community services. There are 7 administrative agents across the state, and each of them have been charged of building a collaborative with hospitals. The hospitals identify what they call the frequent flyers, the people who end up in the emergency room, get stabilized, released. So there's a community outreach worker contacted to help integrate, get them involved with a community mental health center, substance abuse treatment providers. There's local law enforcement education about the issue, and community and faith-based organizations and other supportive services. They're building a collaborative of wraparound services for people. This is where the sites are located. I don't know if you could see that well, but the stars are where the administrative agents are and the counties that they are covering. So it has pretty good representation across the state. So how does it address the unintended consequences of some of the other social issues that resulted? They're providing services. One of the things that I think they've noticed, or I'm most proud that this includes, if you look at Maslow's need of hierarchy, on the bottom is basic need. When you're hungry or you don't have a place to live, you're not going to go for behavioral health care. You're going to try to meet those basic needs, and that's a lot of the administrative agents have provided housing for people, for getting food. There's a real coordination of care by addressing the physical, the behavioral, and the basic needs, with the hopes of reducing the ER utilization and inpatient stays. Because like I said, the state pays for 60% of that, the cost for that. It is very costly. So what is MIMH's role in this? We are looking at the degree to which the project improves outcomes. What are we hypothesizing? We're hoping that there will be increases in enrollments in treatment programs, and that people will keep their community mental health program appointments, community health center appointments, because they're providing transportation to that, increases in housing and employment. And we're hoping that we will show decreases in ER utilization and hospitalization and involvement with law enforcement. Looking at some of the demographics of the group that we have so far, the racial composition is pretty overall what the racial composition of the state, a little overrepresentation of blacks and American Indians. 4% are veteran, and it was equally divided right now between male and female, and we found about 30% are homeless. Dr. Hudson was talking about St. Louis. Unfortunately, this data excludes St. Louis. We just actually got it yesterday, their data. So I'm really curious to see if the racial composition will change, because a lot of what we have right now is from the rural communities where there isn't as much diversity as there is in the urban centers. And also the presenting concerns. 40% have a substance misuse problem. 78% have a psychiatric disorder. 30% exhibit or report suicide ideation. And 17% also have physical health. Insurance status. 45% are uninsured, and 41% have Medicaid. One of the things that the community mental health centers are doing are people who are eligible for Medicaid, trying to get them enrolled in the Medicaid so that they can get the services. They have been providing a whole array of services. In some of the rural areas, people don't have access to their pharmaceuticals. So they have made arrangements with pharmacy to actually take medications to people who don't have the means to get to them. Transportation actually to their appointments. It's a really wraparound services for these individuals. That's about all I have, but I am going to end with some parting words from Rosalind Carter, which is the overwhelming majority of people with mental illness can lead normal lives. They can live at home, go to school, go to work, and be productive citizens in the community. And we have to get the word out that mental illnesses can be diagnosed and treated, and almost anyone suffering from mental illness can lead meaningful lives in their communities. And I'd also like to add the gentleman that I talked about with the 43 ER visits and the 8 inpatient stays. After 3 months with the ER enhancement program, he has had no further hospitalizations. He's currently in school and has a part-time job, and he credits the fact that the outreach worker was able to get him in housing and provide him the supports. So it is a very worthwhile project. It's just now getting off, but I hope to get continued funding because it's a very worthwhile program. Thanks.
Good morning. Have you ever gone to a conference and you're wanting to present and you realize you kind of didn't hit the mark whenever you were preparing your slides? I'm going to, I think, divert a little bit from what I have slides on today to give you a lot of background and information on what we are doing in our county for mental health supports. And we have some very interesting things and exciting things coming out where we are aligning with the school districts to make a mental health co-op to utilize some of the money that may be coming to us from the county mental health tax that passed a couple of years ago. So I was inspired by Dr. Troutman this morning when he talked about the bridge and the stream, because my presentation is an example of something that we're doing within the school district, Columbia School District, and we have done over about 13 years to reduce disparity in access to mental health supports. But also there's a much broader context that I want to put this in. So I'm going to hold my slides until just a little bit later. I wanted to let you know I am the Director of Special Services. That encompasses Section 504, which is kind of like Americans with Disabilities Act in the school district, and also special education. So I oversee 2 disability laws for students with disabilities within public schools within our town, or schools within our town. So as part of that, when the mental health tax passed a couple of years ago, I went to our superintendent and I said, I worry about fragmentation. I'm a school psychologist. I understand systems. I really wonder about agencies coming in and wanting to bring good service to us, but the fragmentation that I feared was starting to occur. So what we did back in September was all school districts within the Boone County area, 6 school districts, got together and formed a coalition. Well, and as you know, if you talk about a problem, then it becomes your job. So I was kind of informally put in charge of this. So much of my work this year has been to help align the vision of the county schools for creating a kind of a concept of a mental health co-op. And that is a model that we're going to put before the Children's Services Board here in Boone County to help to address mental health supports that could be could receive funds through this mental health tax. And do any of you know about this mental health tax that passed. Okay, so it's a quarter-cent sales tax, services for students and families that are from 0 to 19 age. And there's a variety in statute, a variety of services that can be provided. Much of that touches schools. And if you know, schools, of course, their mission is to educate, but we have such concern, such issue with students that come to us with mental health needs. We are zero reject. That means everybody comes to us and we must educate. And that's the beauty of public education. Also, we have child find obligations, meaning we as educators have to find students that are in need of services and provide that. So that really is an interesting dilemma. We have to educate, and also we need to look at mental health and disability categories, find the students who require these services and provide them. So again, in looking at that, or using that analogy that Dr. Troutman had this morning, we were on the bridge and we were finding those little babies as they were floating down the stream, and we were trying to haul the little babies out of the stream. But we know that we must get way, way upstream. So what I would like to highlight for you is one example of something that we have done to go upstream. So you have heard about research and policy. You have heard a large-scale project that is going on within our state. And so now my example that I want to discuss with you is a smaller scale, one school district example of what we have done to go upstream to try to avoid the babies floating down. So that's where I'll start with my slides. Several years ago, about 13 years ago, the Columbia Schools was having a lot of concern with students who were not able to be successful within their regular school. They needed something that was much more supportive of their mental health and behavioral needs. And so we created a program, not a school, but a program where students could go for a portion of their education to receive very significant behavioral and mental health supports. And if any of you are from Columbia, you may have heard of Bearfield School or the Center of Alternative Education. Now we've kind of repurposed that, and it's called CORE right now. The program has been in existence for about 13 years, and we have looked at data. We have made changes administratively, as you do with any program that you oversee. And so now that is my job. I'm administratively over this. So when we were beginning this journey, we had difficulty with understanding who would come into our program, who would exit the program, and in which way they would. So entry and exit. So therefore, you could probably understand that there could be disparities there. There could be differences. You could say, well, I know Louanna, I'm going to get my kiddo in the program because I know her and she's my friend. Well, we wanted to have very clear entry and exit criteria so that people knew that it wasn't like a cronyism sort of a situation where you were able to get your student in for extra supports because you knew someone. We wanted to have clear entry and exit criteria. But as we'd established that, we realized it was so different according to the services that were in all the different schools, and we have 30 schools within Columbia. We even needed to go further upstream and to back it up and to make sure that schools had the access to the supports they needed to support the students within their schools so they didn't have to come to some of the program that's outside their schools, so the students weren't removed from their regular schools. So we created what we call Behavior Support Committee. I mean, not a very lovely type of name, but that's what we called it. Okay, so Behavior Support Committee. It has been in operation for over 10 years, and this committee was to support schools in their working with students who had very, very, very challenging behaviors. We have students that have reactive attachment disorder. We have students that have schizophrenia. I mean, even in middle and elementary schools. We have a lot of schools that had very few resources to work with students, and then we had schools that were larger and had many, many resources. So you had quite a variety of resources within your schools. And we said, we need to help the schools have more standardization, more access to preventative sorts of activities needed to empower teachers to know what to do with students that were having behavior concerns. Because if any of you are teachers here and have gone through like elementary or secondary preparation, that's not generally a focus of your education, is what to do with the student when they're either head is on the table, or they're under the table and they're very depressed, or they're very hyper. You're learning how to teach chemistry, or you're learning how to teach reading or writing. So we wanted to be able to empower those teachers with the skills that they could need. But we also knew that just giving a couple of in-services or having someone come out and give a talk at the school just wasn't going to be enough. So we said, let's create this committee. The committee then has existed, I said, for over 10 years, where teachers, school staff, administrators, counselors, outreach counselors — we have outreach counselors that are social workers within our school districts — they can come for more in-depth consultation for the behavior problems that they have to work within their schools. So it is a prevention process, a prevention focus, and it provides district-level consultation and behavioral expertise to school teams. It is a weekly meeting, and we use a structured problem-solving approach. When I started the Behavior Support Committee many years ago, we didn't really have a model that we used, and as you could imagine, we sat around and talked about the kids, and we admired the problem, is what we say. So we didn't feel like we always came out with something that was very action-oriented for the teachers. And so we moved to what's called problem-solving model. And this is a structured approach where there is time set for different components of the process, and another slide here will talk to you about that. Your participants in this were your school teams. Also, we have school psychologists, and that is my training. We have behavior support specialists that would attend the meetings every week and come up with very creative solutions, creative ideas for the teachers and for the teams to take back and implement. We also had the opportunity to integrate with the MU Department of Psychiatry, and this has been a very long-standing collaboration that's been wonderful for us, and we hear from Dr. Young-Walker, who is their coordinator, that this has been a very helpful training process for the fellows, psychiatry fellows also. So every week we have 4 hours, 1 hour per student. Teams come, and there is a time for them, the team, to present the problem, and then there's consultation about this. I believe that the psychiatrists learn about what it is, what real life is in schools. They also will go out and see students within the classrooms. They will consult with teachers and help us with understanding maybe the impact of medications, the impact or the impact of that diagnosis that the student might have in the classroom. It's very educational for teachers. There also is ongoing support. That was one thing that we did not really anticipate in the beginning of how much we needed to do that. Teachers really need the ideas and then the support given to them for implementing what good work we had done and ideas that we'd come up with. So again, the problem-solving model has been very, very helpful. We have had a lot of good comments about this formal process. So there's a little bit of data collection ahead of time, a little bit of talking about who your student is, what the strengths and weaknesses are. We wanted to make sure that we did not overwhelm teachers, because the paperwork load that teachers have is pretty much unbelievable. We have time limits, just the portions of it, and I won't go into detail. If you want to know what this is, I can very easily give you all the forms, and you can see the nice structure of it. Teachers feel that this is very helpful to them. It allows them to tell their story about the students and also come out with an action plan. So they leave the meeting with an action plan in their hands. They can share data. We are very much data-driven, making good data decisions. And then they also, this is a really nice part, really important part to a teacher, is even though we may give you an idea, maybe it's not the idea you think will work within your classroom. So they are in control. They generate hypotheses of things they may want to look at. They generate ideas, and then they say, this is the one I want to choose in my classroom. So there's ownership of that action that the teachers take at the meeting, and also then they feel like they're empowered, like, that's what I chose, that's what I want to do. And then someone comes to the room and helps them implement that. We have an assigned specialist to assist the teacher in the implementation of suggestions. That component that we added a few years after we started has been extremely helpful. The feedback that we get from this, and we do this yearly, we do data collection on basic kind of satisfaction surveys, useful, very valuable, and very credible results. So this isn't just you go get ideas and you go, okay, great, that didn't really work in my classroom. Teachers find this to be very credible. We also have reduced the number of students who have had to go to that specialized program by using this problem-solving model within our Behavior Support Committee. It's a very safe place, and that's important. You have a lot of investment as a teacher in the success of the student. And sometimes it's very difficult to say, I didn't do well with this student. And to bare your soul to other people that you may not know, it's really difficult for teachers to say, I didn't succeed. Could I have some help? And so this has become a safe place. Again, I think it's been very valuable, school-based training for fellows. They report over the many years we've collaborated that this is one of the most important parts of their fellowship, that they know what life is like in schools for students. One thing that is very valuable to teachers, they don't have to wait a long time to get support, to get consultation, to get to access the committee. So it's very quick. We turn around very quickly. Again, follow-up is greatly valued. The other thing that can come from this is that maybe there needs to be some connection to an agency in the community, to Rural Behavioral Health, to Family Counseling Center, to Pathways, any agency in town, the Thompson Center for Students with Autism, the MUPC, even Juvenile Office. This is only a school-based committee. However, when I have been audited and the others that I train, I coordinate our interagency committee that has agencies around the table every week to support students. So from Behavior Support Committee, many times referrals come to us for interagency to say, this is what this family needs, is agency supports. Probably the most important thing is that it really builds capacity for teams. We find over time that maybe teams would bring many, many students to Behavior Support Committee, but then over time they have built the capacity in their own thinking and use of the problem-solving model within their schools, so they don't bring as many students, because they have built the capacity within their environment to address their own issues. Okay. Yeah, that's all. Thank you.
Thank you very much, the three of you. And we do have quite a bit of time now for some questions and answers.
Just want to remind everyone to fill out their yellow sheet, and I'll be collecting them at the end of the session. So it's really interesting.
Thanks, Amy. Yes, please fill out your yellow sheets at the end of the session. Questions? Yes, sir. And I'm going to repeat the question so that we get it onto the audio here.
My question is addressing Ms. Rita Atkins. This new program the governor signed was the Emergency Room Enhancements Program. If we encounter somebody who's in crisis or is needing this, how would I tell them to go to the emergency room? Should I say tell the patient to go to the emergency room to request the what would be good to present to the patient to receive care for that?
The question is, what would be good for a person or a patient in mental health crisis to present in the emergency room, referencing the Emergency Room Enhancement Program?
Okay, I am not in implementation, I'm evaluating, but the administrative agent at each of the 7 sites, they are a community mental health center, so it's their outreach workers. So I can let you know if I'm not sure where you're located at.
Here
In Columbia, it is Burl that is in charge of that here. Burl Behavioral Health.
Burl?
Mm-hmm. And they have outreach workers that normally the hospital will call this outreach worker and say, I have somebody who we think will benefit from this. They come and meet the person, make the community mental health center appointment right then, and we'll make sure that they make it to the appointment. If they don't have transportation needs, they will come and pick them up and take them to the appointment. But it is Burl who is the administrative agent here. They should know at there, because that is one of the hospitals that is included in the cooperative here, that they should contact one of the outreach workers from Burrell.
Is there a web presence for that program, or is there outreach of any kind that you know of?
I don't really know. We have a website, but it's really just more because we have a data collection system, and each of the sites can access our web-based system to enter the data. But if you contact Matt Gass at Burrell, he will know where to. GASS.
Thank you. Another question back there?
Well, to piggyback on that, I thought you were saying, should I tell the person to go to the ER?
That, I assumed that it would be any emergency room, and if a person's in crisis, to say, I really need assistance with the behavioral health care enhancement program or whatever.
I guess my question to Rita is, I know the whole thing is
To avoid.
Yes.
Yes.
ER visits, so is there
Right.
any way they can access those wraparound services without going to the emergency?
The question is, can someone access the services that are tied to the emergency room enhancement program without going to the emergency room?
And I know that Burrell in Springfield has the CIT, the hotline, ACI hotline, and that's how they are accessing a lot of people there. So I'm assuming that hotline is in Columbia also.
ACI hotline?
What does that stand for?
Access Crisis Intervention.
Because,
Mhm.
you know, like, because I've worked with the homeless people in the Columbia area a lot on projects, and it just seems like if we're trying to cut back on ER visits,
Right.
this would be another shoot that they can go
Right.
to.
And that is how they're doing it. Each of the sites have different implementation programs, but most of them, the hospital recognizes this is a frequent flyer, and they will call an outreach worker and try to get them involved in the community health and any kind of basic needs that they have get those met so that they are more equipped to handle and address their behavioral health needs.
And can I just add that, you know, Burrell has the Access Center, it's a walk-in center here in town. And
Where is that?
Burrell has an Access Center. Yes, and there are walk-in clinics, and I don't work for Burrell, but I just know because of my interagency work that that is something that you do not have to go through the emergency room to go access psychiatric services through that agency. Also Family Counseling Center, you know, many of the agencies you can walk in, however, that agency, as the administrative agent, Burrell has set up an access center for ease of access for the services.
So if you walk into Burrell Access, to access Burrell services, mental health services, will you get that kind of wraparound, like, will you get the connections?
Let me repeat that. So if you walk into a Burrell Access Center where you get the same kind of services that are tied around the emergency room enhancement program.
Yes, I mean, it's up to each of the,
Burrell.
it's up to Burrell,
Right.
yes. Mhm.
Right.
Well, I mean, I think these are all good issues to discuss if,
Right.
if folks are staying for the community,
Right.
data and structure into action, talking about these issues, about how to make them more seamless or
Right.
An awareness program of sorts. So, any other questions out there? I think, did you have your hand up a while ago?
Yeah, my original question was your map, and it looked like a big part of the state was white, which I was gonna ask, does that mean there was nothing there? Or now you said it's Burrell, so does that mean Burrell's all over the state?
No.
Can I repeat the question real quick?
Oh, I'm sorry.
That's okay. We need to get it on audio. The question is, on your map, were the areas of white, the counties in white, not covered by the initiative? And if there were Burrell centers or outreach in those, are they part of that, even though they're not included in the initiative?
There are 7 administrative agents, and in the Columbia area it's Burrell, and in Springfield area it's Burrell, but in Kansas City it's like Rediscover, in Rolla it's Pathways, in the Boot Hill it's Family Counseling Center, and up in the Northeast it's Mark Twain Behavioral Health. And I think this is more of a demonstration project right now, and if it does show that there are reductions in these hospital costs, then it could be expanded across the state. So this started in October 1st, which is why we have a lower end, I think, right now, because some places had difficulty getting MOUs between the different players in the group, so the implementation took a little time to get going. But everybody's working really good right now and very excited about the program.
Yeah, I think that's an important distinction. I mean, I've been calling it an initiative, and as a demonstration project is a bit of a different beast here.
Mm-hmm.
Did that answer your question? Yes.
Just to add to this discussion a little bit, I'm from Pettis County, and when we were a white county on the map, but we are also working with this project. We have Matt Gass, he used to be in our county, so we know him very well, and he has actually helped us bring together a community working group, and we have one hospital that is trying very hard to make appropriate referrals to Burrell, because often in small rural communities you have a lot of trouble getting referrals to the right place, because we are a highly uninsured county, and so people don't have resources, they don't have support. And it's been a very interesting working group, because at the first meeting, the sheriff said, "I am the mental health secure facility for this county." And I am working very hard with my officers and the city police too, to not say to people, okay, your options are straighten up and go to the emergency room, or you're going to jail. And so that is an issue, at least in my county, to try to get law enforcement to say there's another way for people whose behavior is causing distress, not only in the community but among their family members, to not say your options are the emergency department or jail. And that's where part of this project is trying to work in our community to stop some of these frequent emergency room visits, because what's pushing a lot of emergency room visits in our community is when families call and say, I can't handle this anymore. And so there's nothing to do, they think, but take their family member to the emergency room.
Yes.
And so that's how it's slow, it's not speedy, but this is how one initiative is trying to work in a rural community.
And I do know that Burrell is working hard, especially in the Springfield area, to educate the law enforcement agency that don't take him to the emergency room, contact this access center and get them involved in the community mental health center for care.
A lot of opportunities for action on the community side. Domingo, you had a question.
Yes, and you will understand how ignorant I am of these issues, but I'll try again. Prevention. I do know that mental health is a very complex process, and it has a lot of societal and cultural components to developing that. But there are some very clearly identifiable stressors in some cases that could be addressed somehow as a preventive measure. I'm thinking about the work we do with immigrants, especially in rural areas. You do have there, and you have been working both with immigrants members of the receiving community. And among the in the interviews and surveys that we do, we find some stressors that I believe are conducive to mental disease. Among the immigrants, for instance, especially among the women that don't work, but don't work outside the home, they are extremely isolated. So, and that is very clearly conducive to depression. And in the receiving community, you do have another component, aging population, which is also isolated and tends to be depressed. And there's also the fear to the other. The immigrant fears the receiving community, the member of the receiving community fears the immigrant, and all those stressors are very conducive, in my very ignorant opinion, to possible mental health conditions. So, is any of you, and this may be a question not only for the panel but for the planning committee, which includes me, by the way, is the question is, are we doing anything to understand and to control those very visible stressors that may preclude the development of more mental health issues?
So the question is, given all the complexities that go into mental health conditions, are there easily identifiable stressors? You mentioned the immigrant population, but just in general, I assume that can be addressed to elevate the issue of mental health needs.
Let me put
Okay.
one example that I have in my head now, because we were working in three proposals this week, and I have the numbers in my head. Imagine the community of Nolan, Missouri. It is in the southwest corner of the state, almost Oklahoma, almost Texas. In 1990, in that community, there were 19 Hispanics and around 1,500 white people living there. Okay? Today, 50% of the school population are Mexican. So how that change affects members, all members of this community, both immigrants and receiving community. Can we identify some stressors there? And examples like this you will find, Milan, Missouri, 5 Hispanics in 1990. Today is 49% Hispanic. Because of immigrants. That has to produce some stressors. Cultural barriers, aging of the local population, and so on and so forth. Is anybody doing anything that can help to address this issue? I know in Missouri you can find Somali immigrants.
Absolutely. Dr. Hudson, is that something that you can speak to?
Yeah, sure. So I appreciate that perspective because I've only been here for 3 years, but I haven't heard a lot about the immigrant population in Missouri. So I think it's something that we know that there's patterns that affect that population. And I think unique to Missouri is this urban-rural type of demographic here as well. But to your point about knowledge about stressors and prevention, at least in the work that I'm familiar with, we know what the major stressors are. Their financial strain, their concerns about education, their things like that. The bigger issue, and that stuff affects, and I'm sure Dr. Troutman talked about this earlier, these upstream issues affect every disease outcome. The broader issue is, do people care about that? And I think that's the part of the raising the awareness is, especially for immigrant population, like you said, shifting demographics. Are people aware of those shifting demographics, and do they care about that subpopulation and what's in their best interest? I think that they should care from a financial standpoint, from a health and well-being standpoint. But for me, sitting here listening to you, I think I'd love to talk to you more about those issues, but I'm not aware of it on the other side of the state. And I think that you can see the same thing within our bigger urban centers, like in St. Louis and Kansas City. People aren't aware of the disparities that exist in those cities. We know what the antecedents of those outcomes, mental health included, but the broader issue to me is raising awareness and care about those broader social determinants of health?
I can speak to some actions that Columbia schools are taking. It's not something I have full awareness of, but I can give you some information. We have kind of basically two populations of immigrants. We have refugees, and then we have basically immigrants that do not fall within the refugee category. And many students bring their families when they come to the university. So we have kind of an educated population, and we have a refugee population that has, come from many different life journeys. And so we do see a lot of mental health issues with students that come from different places and different stressors in their lives. So one thing that has been developed over a few years is their immersion centers. So classrooms and kind of little mini wraparound programs within our schools for students who come and are immigrants or refugees, again, mostly take advantage of this, where maybe they don't even have literacy in their first language and, in their L1. And so we have a lot of family issues that can be impinging upon their ability to succeed. In years past, many teachers would have these students in the classrooms and say, oh, they must have special education needs. Well, maybe yes, but our federal law says you have to have had some consistent instruction before we can determine whether or not you have a disability, and like a learning disability. So there are some little boundary issues there that we struggle with. But I do know, just to kind of get back to the point, yes, we do work with families as part of that student's life. And the English as Second Language department here, ELL department, works a lot with activities to make families feel welcome in school. They go out to churches, to places of worship. They go out into areas in the community, help picnics, to try to help families maybe not feel that isolation. But I think we could always do more. I really do. I think your point's well taken.
Well, thank you. I'm sorry, we don't have time for any more questions, but please keep those questions fresh, network with folks as we head into lunch here and for the rest of the day. I want to thank all three of you for providing your unique perspectives on this issue. I think it creates a lot of interesting thoughts for the later conversation about turning data, demonstration projects, and so forth into action along the lines that we've seen here. So thank you very much, and don't forget to fill out your yellow sheets.